We will finish grids with this recording and we'll be done with recording for the semester. So this will be the last lecture recording for the spring semester. So in the last recording, we were talking about problems with grids and grid positioning and what would cause grid cutoff. And we said that off-level grid was a problem with any type of grid. Off-level just meaning tilted. We talked about off-centering, which is what we have here. Off-centering would be a problem primarily with focused grids, and included in that would be focused crosshatch grids. So where you have off-centering is laterally. So we've in tilted grid, the whole grid is tilted, and with a off-center grid, what you've got is a focus grid where you're not centered to the midline of the grid. So you're off-centered laterally towards the side of the grid. With a off-focus grid, that's specific to focus grids, and it could be again crosshatched focused or just linear focused, and that's where you've exceeded the focal range of the grid. So your SID is either too far out or too close, and then one that's again specific um, to focus grids is an inverted grid or an upside down grid. And that's where your grid lines are opposite from the divergent central ray. So what you've done in canting the grid lines is actually makes the grid cutoff much worse in an inverted grid. What you get is good density in the middle, and then immediately you get grid cutoff. So the only place that you get good density is right dead square in the middle. You get on an off-level grid, you get grid cutoff across the entire grid. With a off-center grid, you get density that's okay on one side, really bad on the other. With a off-focus grid, you get density that's good in the middle, but the further out you get, the worse it gets. And with an inverted grid, you get good density in the middle, and then immediate grid cutoff anywhere outside from the center of the grid. So that's just the explanation of each one of those. Off-level means tilted. Off-center just means laterally. It's specific to a focus grid. Off-focus, again, means too far out, too close in. Inverted means upside down. And the results for each one of those, for the most part, are going to be grid cutoff somewhere. So your grid selection, because of the patient dose is going to go up dramatically when you introduce a grid and whenever you change grid ratios. So if you go from no grid up to a 16:1 grid, again, your entrance dose is going to increase dramatically, depending on what your KVP is, what KVP level that you're using. I'm not going to ask you questions on entrance skin dose, but you need to understand that whenever dose is a problem in selective populations like pediatric hospitals, most of your pediatric hospitals, because of the youth and the developing bony structure and the exposure to blood-making bone marrow, and that children are more radiosensitive, and the exposure to the gonads and the whole 9 yards. What your pediatric hospitals in a lot of cases will do is to use a low ratio grid. So if you were working in children's, for example, your grid ratio may be no higher than 8:1. The average grid ratio in most hospitals is going to be about a 10:1. So dose is going to be relatively high with most grids, possibly 8:1, but in a pediatric hospital, in a lot of cases, they're going to use a 5:1 grid or some sort of grid ratio that is more conducive to lower dose for the patient. So how do you calculate the change in technique whenever you change grid ratio? If you happen to go from no grid up to a 8-to-1 grid, well, we're going to roll back up to our Bucky factors here. So if you were to go from no grid to an 8-to-1 grid, according to the Bucky factors I've got here, and these are your testable Bucky factors for this test, then you would need to increase your mass by a factor of 3. So if you were to take a KUB on a patient at 80 kVp at, let's say, 10 mass with no grid, if you were to introduce a grid, you would multiply your mass by your Bucky factor. So it'd be the 10 mass times 3. Now you would shoot to receive the same relative density. You would use 30 mass instead of 10. So if you were to use a 16-to-1 according to these Bucky factors, you would use 50 mass instead of 10 mass. So going from no grid to a grid is all you would have to do is multiply by your Bucky factor. Conversely, if you were to go from a gridded technique to a technique with no grid, then you would divide by the Bucky factor. For example, if you found yourself up on a hospital floor and you didn't have a grid on you, and they just put an NG tube into the patient, there are times that it is kind of appropriate to shoot an abdomen, let's say, without a grid. Those cases are fairly rare, but let's say they've just put an NG tube into the patient and they want to make sure the NG tube was below the diaphragm. The most common place for an NG tube to go would be, if it doesn't go into the abdomen and down the esophagus, would be into the right mainstem bronchus. So generally, whenever you're shooting a KUB for an NG tube, you don't really shoot a KUB. You shoot like a low chest X-ray or a high abdomen. So the top of the image receptor would be up around the right mainstem bronchus. So that you could, if you didn't see the NG tube on the KUB, you might be able to see where it is. Is it still in the esophagus? Did it hit a Zenker's diverticulum in the esophagus, or is it in the right mainstem bronchus? So you'd shoot a KUB that is not really a KUB. It's like a chest X-ray where you clip the apex of the lungs, or a KUB where you position more like an upright abdomen. So since the only thing that you're looking for is whether or not the NG tube came below the diaphragm, you can kind of get away without shooting the abdomen with a grid. So in a case like that, you would position high and you could shoot without a grid. Most of the time your techs are still going to shoot with a grid, but if you don't have one, it's really not worth going down to the department to locate a tape-on grid to go back up to the floor and take an X-ray on the patient. So let's say you've got a decent technique for the patient. Patient's on a size of an average person that you would shoot, say 80 to 85 kVp at, let's say, 36 mass. Well, and that would be a normal gridded technique. So if you were to be shooting that same patient without a grid, what you would do is, if you had an 8-to-1 grid normally in the machine, what you would do is divide it by 3. So 36 mass, now you would shoot with the same KVP that you otherwise would have shot with, but you're going to use 36 divided by 3 would be 12 mass.